Hello, everyone, and welcome to the International Interprofessional Mentorship Meeting. I am Dr. Kate Barlow, the founder and host for today's meeting. It's October 12th, 2021, and today Dr. Patrick Carley, physical therapist, is here to talk about how to choose a mobility device. Please mute yourselves during the presentation and unmute yourself whenever you would like to ask a question, or you can type your question into the chat box and I will ask the questions for you. In order to receive a certificate of attendance, please enter your name and email into the chat box now, and you will need to remain on the webinar until the presenter is finished. At the conclusion of the presentation, we will have an optional meet and greet. Thank you all for coming. Thank you to Dr. Patrick Carley so much for coming. We really appreciate you coming today.
Well, thanks for inviting me. This is quite amazing. I'm kind of overwhelmed a little bit, like, to see everybody actually in another continent, and we're talking about things that are just so common to, people on both continents, so this is quite amazing. Kate actually shared with me a little bit about the history of how you guys are starting this relatively new profession. So I would like to have, me learn a little bit more about you also as we go through this, because it is kind of fascinating to me. But I would like to share a little bit about what my background is, so you kind of get a sense as to, my perspective on things when we talk about mobility. And then the other thing is that we would kind of engage different topics. Maybe we can get this more as a discussion going back and forth to explore different clinical reasoning behind why you would even think about this device over another device, and what would be the kind of the patient symptoms or pathologies or anything like that that might direct you in those decision-making processes. So if we can actually, keep in mind that, if you have questions pop up, I'd like to keep it somewhat animated if we could. I know Kate was saying that you guys like to use a chat room or something like that, but feel free to just jump in there and ask some questions, or even challenge me as like, hey, why are you thinking about that? That's kind of crazy. And then we can talk about the clinical reasoning behind that. So I've been a practicing physical therapist for a little while, about 43 years. I was in naval intelligence beforehand, and it was great. It was kind of a fun profession, naval intelligence. You get to be involved in some very high secretive stuff. But at the end of the day, if somebody said, how was your day? You'd say, well, great, I can't kill you. I can't tell you, or I'd have to kill you. That's that. So that got kind of old after a while. So I wanted to get into a profession that was really more challenging. And a friend of mine got into a car accident, and I was, after the Navy, I went to college, and he needed some help. And so I took him to therapy. It was occupational therapy and physical therapy. And when I saw what they were doing, I was mystified. I was like, I knew right away that that's what I wanted to do. And so I've never turned back. I think it's a fascinating profession. I tell people all the time that, it's one crazy profession. If you think about it, you're meeting people on the worst possible terms, right? Something bad has happened to them, like a disease or a surgery or an accident or something. So it's not the best time to meet new people, if you think about it. And then the second thing you do is you put your hands all over them. So it's kind of a crazy profession, if you think about it. But one of the things I have found that really is amazing is that they rely on us to take our training and to help them integrate back into life, right? The important thing now, they used to talk about lifespan, and now they're talking about more like health span. How can you maximize your ability to get physical with the world, get around in the world? So I have been teaching at AIC, where I met Kate. And before that, I was at Springfield College for about 11 years. And before that, I was at Northeastern University in Boston. And I taught a lot of different courses. But one of the things that is always really important for us to understand is how to take that classroom knowledge and apply it to things like, how do we maximize somebody's mobility? And why were we thinking about that? So there's a lot of reasons why you would even think about considering a device for anybody, really. It's like, it could be children, it could be older people, it could be younger people that are hurt in maybe a sports injury, car accident, or maybe something else happened where they had some pathology or disease that they needed to use some device to maximize their independence out there. And you have a lot of choices. You really have like a wheelchair that kind of helps out. You have a walker, you have forearm crutches, regular under the arm kind of crutches. You have what they call quad canes that have 4 feet to them. I have a couple of examples here so we can show you and talk about that. But before I want to get to those devices, I want to talk about what would be some of the reasons why you would actually consider using a device in the first place. And one of the things we talk about, and that is that because we are upright and we're standing and we walk around on 2 feet, that bipedal nature is something that we've evolved to. And it's amazing when you start to look at our anatomical structure. It's really designed so well that we can balance 70% of our body weight. That's like 70% of our body weight. So if you weigh, let's say, 200 pounds, you're balancing essentially 140 pounds on 2 feet. And then sometimes you're just doing it on 1 foot. So that takes a lot of balance. It takes a lot of awareness as to where your feet are. You have to have coordination of those limbs, shifting the weight from one side to the other side. You have to be aware that you're actually putting weight on the other leg. There has to be a limb to actually step on. And there also has to be the ability to advance the limb safely so you can actually anticipate putting all that weight on that, again, at 1 foot. So there's a lot that can go wrong if you think about it. So that's what we have to deal with when we start to think about devices, is where is the person? Where are they starting from? And so now we can kind of figure out, all right, if they can't feel that 1 foot, then they're going to have some difficulty being aware that you're actually putting your foot down on the ground and then shifting all that, let's say 140 pounds onto that limb. Sometimes you'll see that if you are in a position for a long period of time, you're actually cutting off the blood supply and compressing the nerve. And so after a while, you're maybe watching a movie or you're intense on studying or reading or whatever it might be, and all of a sudden you decide to get up. And you might have felt this very common thing when you go to stand up and all of a sudden you can't feel your leg. When that happens, all of a sudden you notice that your whole walking pattern changes. You can't walk the way you normally walk. So in that case, you can see where a device would come in and help out. If for some reason you're dealing with somebody who has lost part of their limb, now they don't have a limb to stand on, right? So sometimes they get a prosthetic device, but then they have to learn how to actually anticipate bearing weight through that prosthetic device. So they're going to need a device to help them. Then you have people that maybe have suffered a stroke where they're unaware of that one side. They can't really feel it, or it's weaker on that one side. You can see where they're going to need a device for that. You can see if somebody came out of surgery where all of a sudden they can't bend the limb, or they can't really work the limb because there's a lot of stitches in it and it's just in a brace, they're going to need a device. Then you have people that have bad coordination. Just something happened bad to their coordination, whether it be disease or head trauma or something like that. So they're going to need a device to actually become a little bit more independent in their function. So you also see, lastly, you can see that some people have issues with their balance. As people get older, they have difficulties with their balance. They might have sensory problems, coordination problems, muscular imbalances, or all three. So they would need a device to safely avoid falling and injuring something. So we got a ton of reasons to think about when we start to think about what device should we use. And then when we think about that device, we have to think about it, as I try to tell my students, that think about the device as being temporary. So essentially, you might start out with a very strong, well-established, very stable kind of device. But as us therapists, we have to think about how can we move that person from using a very stable device to maybe even think about using devices as a transition, to finally getting to that device that's smaller, a little less stable, that allows them to move around a little bit easier. So that's what I wanted to do, is actually kind of lay the groundwork as to what you would think about when you think about mobility, and then and which choice of device. So in your thinking, then essentially what you should do is try to look for the device that's going to be easy to handle, easy to manage, but be that one that provides enough stability so that when the person does use it, they can maximize their mobility safely. So in the beginning, they might have some weakness, and then as you get them stronger, they might not need, let's say, a walker or a very stable device. Now you can move to maybe crutches or forearm crutches. And then you can come down to one forearm crutch, and then maybe to something even less stable, like the four-pronged, what they call large base quad cane. And then finally to a cane, where the cane is really the most unstable device, because you're using your hand to push down on the device, on the cane, but the cane is actually has a very small base of support. And so when we think about it, the most we can actually put on that cane for support is about 15% of a person's body weight. Not very much. So at that point, they must have transitioned to greater strength or greater range of motion, a better healing in the, let's say they had a fracture. Now the bone has gotten stronger, so that now you can start to think about progressing from a walker to a cane. When we start thinking about fractures, we have to realize that as the bone heals, in the beginning, the person might actually have to be non-weight bearing. So in that case, you really need something stable. So we think of a walker. And then as they progress, they might be a little bit better, and they can use crutches or maybe forearm crutches. And then as the bone heals, we start to see where people will actually be able to tolerate, partial weight bearing. And then finally, as the bone heals even more, they can go from partial weight bearing to full weight bearing. But the bone might be fine, but the muscles around there are typically not, or the joint is too tight to allow for the leg to actually bend so that you can actually clear the leg and put it on the ground. So that's the kind of thinking I want you guys to start thinking about when we think about the balance of mobility and devices back and forth. So I have back here some devices. So we have kind of the standard gait belt we wrap around people. I'm not sure, do you guys use gait belts where you are? Like something like that. It's very simple. It's very common in the United States when you're in a clinic and you really are unaware of how stable the person is. That typically we will wrap this around their waist. And then what we'll do is we'll hold them typically underneath. So that way, if they fall, we can hold them. If we hold them the other way, you can see what happens. They fall and like we don't have a good grip on that. So we're using a gait belt to kind of explore, different some different devices that would be really good for the person. Right. So going back, we have the walker. In this case, it's got wheels on it. So it's a little less stable than the one that has no wheels on it. And so I'll tip this down so you can see it a little bit better.
Could you bring it closer? It's hard to see.
Oh, sure. I can get this. All right. So I'll leave this off to the side. This off to the side. This off to the side. And so here's our walker with the wheels. Typically what will happen is you'll see that the walker has all four of these legs like this. But in this case, because the person is getting a little bit better, we can now put wheels on the front on both sides. And then when the person is actually moving, they just have to lift up the back wheels and they can walk with it. So now we can see where all of a sudden we're using a walker that is somewhat in itself. We can just change the legs on the walker. So I'm going to show you that. So we can actually change these, change them out, and actually put these legs on there that are really stable. And if they get really good and they get a little more stable, then what we can do is we can take those legs off in the front, and then we can put these on here. And that increases the person's mobility quite a bit. So in this case, we feel a lot more comfortable about the person in their balance, in their coordination, and then also in their muscle strength, that they'll be able to weight shift from one leg to the other, but they just need a lot more support. So this is kind of a nice walker, if you think about it, because it can fold and be transported, like say in a car or some public transportation, really easy. And so the person could take this wherever they're going to be going. Some people actually put a basket in the front here so they can store different things in there and then still walk around with it. So that's a walker as a device, but in walkers, we go from something very stable where we have all four of these legs on there, and then we get to be a little less stable with the wheels on there. Still providing a lot more safety to maximize the person's mobility. So you guys have any questions?
I have an update from you. So Erica in Guyana said that yes, they do use gait belts, but Abraham, who is in Nigeria, said no, they do not use them, or they're not common in Nigeria.
They don't use gait belts.
Correct. He said not common here.
Not common. So is there a reason why, or is it just something that it's not accessible, or is there any particular reason why? I mean, I'd like to learn a little bit more about that. I mean, because everybody has got some kind of device like a belt that can hold their pants up just in case. So you can also use a belt, not necessarily something as fancy as this, but you can actually use just a regular common belt to help control the person's stability as a therapist. Basically because people don't come with handles typically. So it's a great way to be a little safer with your patients. It's just have this kind of a belt. It's a cloth belt. So you can actually use a piece of cloth, a strip of cloth, or some kind of just your own belt from home. Maybe you have a belt you don't like anymore, you can, or your boyfriend or your husband doesn't have a belt they like, or they have too many belts and you bring in an extra belt, just something like that. I think it's just as you're trying to think about using what device to make a person more mobile, as therapists, we're always challenging the patient. And when we challenge them, we make it really unsafe. And we don't want anything to go wrong. We don't want the person to suddenly trip when they're really under our guidance. So a gait belt or any kind of belt or cloth, rope even, anything that you can help stabilize that person to avoid them falling and getting injured. So that's why I'm so crazy with the belt thing, but it really ties in to when you're trying to figure out what device, the first thing you're always thinking about is safety and how can I maximize my interaction with that person safely, but still challenge them, really physically challenge them, so that they're not afraid when we're challenging them, because we're guiding them, we are supporting them, and we're making it a safe environment so they can explore, make mistakes, but you're not paying a big penalty by falling on the floor or getting hurt further. Does that make sense to you guys? A little bit? All right. So
yes, it does make sense, sir.
oh, good. Yeah, so get those belts and anything else, because it's a good thinking for when we actually work with patients going forward. Good, I'm glad. Cool. All right, so you guys have any questions on the walker? This is kind of a common device here in the United States. We see those all the time. They, when they started to make them be able to be folded, that really increased the person's mobility. If you think about it, trying to get on public transportation, once you're in the bus, and then you're trying to kind of move this thing around and get it out of the way so nobody's going to trip over your device. Folding it up allows that person just to feel a little bit more comfortable having to use that device. So you can imagine how much room this takes up. Huge, right? But if we suddenly just push the button and fold it up, you can see how much more compact that can be. And then when they're getting off the bus, they can just unfold it. It locks into place. You can hear that click, and then it becomes pretty stable to actually start to allow them to be safe and mobile at the same time. So that's the walker. Sometimes, probably Kate can tell you that if these things in the back get wore out over here, these pieces, sometimes they come with replacements. Sometimes you don't have the replacements. And a very common thing they do here in the United States is that they cut a little slit into a tennis ball. And then they kind of squeeze the tennis ball and they put that at the end of the walker. So they put it essentially right there. So they got the tennis ball right there at the end. And that allows for it to slide across, let's say a floor, like a wooden floor or smooth like concrete floor, something like that. It allows it to move fairly easy. Otherwise, you'll be able to hear that person coming down the hallway a mile away, just like the metal is digging into the concrete, and you hear them kind of like screeching along. So just another aspect of how to use a walker, a rolling walker, or maybe one that doesn't have wheels, to be very stable. And again, think about the devices as just being a very transitory type of thing. So you're just going to use it temporarily to get them stronger so that they can move on to the next device. So we're good there before I get onto crutches? I think so. Oh, we got a thumb up. So Nora says we're good. I guess we're good to go. We're ready to move on to the crutch. All right. So we'll get the walker out of the way. I don't trip over it. All right, so there are two types of crutches, actually three types. These are what they call forearm crutches. So the way this works is that your arm goes in here and then your hand goes here. And so you have 2 points of contact here with your hand and here. It's usually measured and adjusted so that it goes just below the crease of the elbow. That allows for a lot of range of motion as you're walking. And they're pretty easy to adjust, not only at this piece, but also down here, so you can adjust the height. These are pretty stable, and we have found that, especially younger people, they want more mobility than the forearm crutches that go into the armpit. So we have found that these offer a much better mobility, and they can actually walk around with a lot more confidence as they start to move around. So the way this looks is just like this. And you can see here where we start to now have the mobility to get away from the walker, which is kind of fixed, right? This allows us to start to move much more like we would normally walk. So when we walk, we usually have, let's say the right hand goes out first and then the left leg. And then we'd have the left arm and then the right leg. So that's how we would normally start to migrate towards a more normal walking pattern, gait pattern. And the reason for that is all part of that whole thing we were talking about with mobility in ambulation walking. That when the one leg goes out, the other arm acts as a kind of a counterbalance. So we have to make sure that if we ever have that ability to move the person away from the walker, now we can see where we can have alternate limb swinging, which actually allows for a lot better control on your balance. But when it happens like that, it actually allows for a lot more normal mobility. And again, that's our whole purpose for getting people to start thinking about what device and what are we looking for in mobility. So now we have the opportunity to get away from the walker and use these crutches. Again, these are forearm crutches. And then you have the what they call axillary crutches. Axillary meaning that the top of the crutch goes into the axillary area. So they call it axillary crutches.
So Dr. Carley, can I ask you a quick question? Can you use the forearm crutches with a patient who's had an amputation?
Say that again?
One of the questions was, can you use the forearm crutches on an amputee?
Yes. Yep. The forearm crutches, particularly in younger people, work better for increasing their mobility for younger people that are amputees, and also younger people that have like cerebral palsy or some type of neurological pathology, where all of a sudden now they're limited in the movement of their legs. So for an amputee, with the forearm crutches for a younger person is really the best way to go. For younger people that have, let's say, cerebral palsy or spinal cord injuries, but not a complete spinal cord, what you can do with this is actually you can start to maximize their mobility by teaching them different gait patterns. Now, are you familiar with some of the gait patterns that go on? Well, I'm going to throw out like a couple of gait patterns. Like when you walk, you only have 2 feet, like one moves and then the other one. So you only have 2 points of contact, which means that you have to have a maximum ability to negotiate balance, sensation, limb advancement, all those types of things. But then there are some people that have lost their coordination, or they have bilateral leg weakness. And so their legs are unable to do that. They're not strong enough, or they're not coordinated enough, or they don't have the mobility in their legs. So we use the forearm crutches to maximize a gait pattern called a 4-point gait. So in other words, we have 2 feet, and then we have 2 points on the end of the crutch. So we get two points on the crutches and 2 points on the feet. So we start to advance the person in a very stable transition from a walker to this using what's known as a 4-point gait. So I'm going to show you what that looks like. I'm going to bring this back down again. This off to the side.
I don't know about the rest of you OTs in here, but I've never learned any of this. So this is great.
All right, so I'm very unstable with my feet, both legs, but I can actually think about putting the forearm crutches like this, right? So right here is my base of support. That's it. So it's relatively small. So the smaller the base of support, the trickier the stability is for the person. Now, if I use these forearm crutches, now when I put it out there, look at the size of that base of support. It is huge. It just tripled. So now I'm really, really stable. And now when I walk, I can move 1 point at a time. And that's why I call it a 4-point gait. So if I step back here a little bit, you can see a little bit better. So I would do 1 crutch. So that's 1 point that moves. And then I would move this leg, right? And then I would move the other crutch. And then I would move the other leg. So at any one point, there are 3 points on the ground, which again increases that. Look at that. If I just lift up that leg, you can see if I was an amputee, you guys look at the base of support I have. It's huge. So I can actually use those in what's known as a 4-point gait. So 1, 2, 3, 4, 1, 2, 3, 4. So there's a 4-point gait. For the person that asked the question about the amputee, now what we have is what's known as a 3-point gait. So we have 1, 2, and then 3. And so this is very stable. So I can actually move like that using what's known as a 3-point gait. So if I had something like a fracture or an amputee, and I was younger, I would prefer these devices because it gives me that ability to just move around a lot freer because I have the strength in my arms and the endurance. Okay. So that's a 3-point gait, right? So now you can see it's pretty easy to figure out. So there's another one that we actually do is called a 2-point gait. And so we can actually do something like these guys go together, these guys go together, these guys go together. So there's what's known as a 2-point gait. I'll do that again for you. So we go 2 points there, 2 points there, 2 points there, and 2 points there. So just to review real quick, the typical patterns that we see with crutches, forearm crutches, platform crutches that have little platforms on them so that they would be like this, and I can rest my whole elbow and forearm on there. And then we have the axillary crutches that go up to the armpit. So here's the 3 gait patterns that go along with the crutches. So we have the 4.1, 1, 2, 3, 4. 1, 2, 3, 4. And so the 4.1 is very stable, but we want to get the person to really get mobile, right? We want to get them mobile. We don't want them to have the same gait pattern forever. We want to get them a little bit faster. We want to get them moving around a little bit freer. So that's why typically you'll see that you'll teach somebody to go from a 4-point gait to something like a 2-point gait. And you can see how much freer that is. It increases my mobility quite a bit. So the 3-point gait is the other one where we talked about it being like this, or you could have both legs like this, and you can have that point. So both my feet represent 1 point, and then you got the crutches. So here we go. We're going to go. And so that would be a 3-point gait also. So we got 3 points because the 2 feet are actually counting as 1. So those are forearm crutches. Again, think about you can adjust where how far this extends right there. And then there's another adjustment that actually changes the length of the crutch right there. So that's crutches. All right, you guys have any questions about that? That's a kind of a lot all of a sudden being thrown at you.
There's a few that have had this training before, which is impressive, but I certainly have not. I have a question about the cane, because I've seen people use the cane so differently, but please correct me if I'm wrong. Aren't you supposed to do it the opposite? So like you would use the cane on the opposite side. Can you show us how you would use a cane? And for like, if you had a left-sided weakness versus a right?
Yep. So, but we're good on the crutches though. Everybody.
Seen any questions?
Nora, how are we doing? Oh, another thumbs up. I'm gonna have to put that on my refrigerator tonight. All right. All right. So let's talk about the cane, right? So now we're down to the last devices that you'd be getting ready to get the person to be very mobile. They're going to have to show you that they are very good at their balance at this point, that they're really good at their coordination of their legs and their trunk, right? They have the strength to actually pull this off, or they're getting stronger. They might have some maybe some balance issues, or maybe weakness in one hip, or one hip might be very arthritic and they can't put a lot of weight on it. So this is the interesting part. So there's two types of canes. There's the old standard cane. It could be aluminum like this. It could be wood. Could be plastic, could be anything, right? This is the other canes we were talking about. And look at the base of support here. Because it has 4 prongs, right? They call it a quad cane. Quad meaning form, like quadriceps, there's 4 muscles in that group. So this is called a quad cane. And you can see when I put my head in between there, you can see it's kind of big, right? So this creates a very large base. So they call this a large base quad cane. So large base LBQC, if you're into abbreviation. So large base LBQC. And so they also make one that's actually kind of like this wide, right? And so the prongs here are actually maybe half of this, but it's still 4 of them. And now that creates a smaller base. You'll never guess what they call that. Do I do that theme from Jeopardy? Then I go. Okay, so essentially they call it a small base quad cane, or SBQC, right? So if somebody needs a lot of help with one cane, they're able to get off the crutches, but they still need a lot of support. We go to a large base quad cane, and then when they get better, then they can move to a smaller base quad cane, right? But it's still not like this, because now you only have one base, one little area, one point of contact right there. So the person's got to be pretty good. So typically you will see people that have suffered what they call a hemiparesis, let's say through a transient ischemic attack, a TIA, or they've actually suffered a full-blown cerebral vascular accident. And so this case, what we do is we use a large base quad cane. So this creates a much better stable environment than the regular cane. The other thing that's really kind of interesting about this, and that is that this kind of arrangement of the prongs, you can see this is the side where the foot would be going by, and this would be to the outside. So you don't want these prongs to be there because the foot would get caught and then we get into trouble. So you can see where the quad cane is actually, the prongs that are closest to the person are actually bent in relative to the other side. Okay, so it's kind of unique. So I'll show you how that looks. So let's say I had a stroke on the left side and I couldn't really move that arm that well. So I would just bring this down just a little bit. And so in that case, I'm going to be swinging my foot right by where those prongs are. So I can see when I put the cane out, then my weak side, my left side, I can shift a lot of my weight onto that, and the cane is very stable, right? So you can see where I'm pushing down and might have a chance to roll out, but because the prongs are sticking out further that way, it's very stable, right? So I would walk like this, and walk like this, right? So that brings us back to Kate's question. Kate's question was, well, do I put it on the right side or the left side? So here's the interesting thing. In the movies, they always use it on the wrong side. So if you see something in the movies, they do that to make it look more dramatic, right? They don't do it the right way because we do it the right way to make it easier, more mobile for the person, right? In the movies, they got to make it dramatic. So I'm going to show you two variations on a theme. So this is the one in the movies. All right, you ready? All right, so that's in the movies. You can say, wow, that person really's got a bad leg. But in real life, as therapists, what we do is we do it on the opposite side. So now, since this is still my hurting side, right, I'm going to go like this because this is where I need the support. So now I can see I put it on the opposite side, right? There's two reasons for that. And one is that I use it on the opposite side because remember I said that you can only do 15% of your body weight with the arm, only 15%. So if you hold it on the same side, it's just 15%. If you weigh 100 pounds, the most weight you can actually shift your weight onto that cane is 15 pounds. So that's not so great, right? However, when we look at it from a kinesiology standpoint, if I now put the cane on the other side, right? I've got, let's say, 2 feet over here. So now I'm able to displace 30 pounds over here, because it's actually 2 feet times the 15 pounds, then that's what they call 30 foot-pounds. And that's what the body deals with. So over here, right, I can only do 15 pounds. But if my leg is still bad on the right side, now with it over here, I can actually displace 30 pounds. So that is pretty amazing. Remember I said there was two reasons. The other one is that look at my base of support when I put the cane and my foot together. If I lift this up, right? The base of support is like really small. If I put it on the other side, look at the base of support between here and here. Huge. It's like 2 feet. It goes from like 2 inches to 2 feet. So again, remember we talked about when we have a greater base of support, we're actually providing a lot more stability. Lastly, if you think about it, when we walk, remember the right arm goes with the left leg, the left arm goes with the right leg. If you think about, again, the last thing to really want to put on the opposite side is that we're mimicking our walking pattern. So if you think about it, we're doing just exactly what we want to do to advance the person. So we're increasing their mobility, increasing their safety. And you add that up, you're creating a much safer and progressive environment. So remember in the movies, they always do it on the wrong side, because if we did it on the side that we know best, it wouldn't look so difficult. And that's what we want to do. We want to have people use devices to maximize their mobility, so it's not difficult for them. So does that make sense to you guys?
Yes, sir. Please, I would like to ask, who prescribes these adaptive devices? Is it occupational therapist or physiotherapist? The reason I'm saying it that if I find myself in a place probably where there is no physiotherapist, is it right? Is it appropriate for an occupational therapist to do both maybe gait training and also prescription of these adaptive devices, considering that they are more for maybe lower limbs, so to speak? Thank you.
That's a great question, because most of the time, what we see is that the therapist will be really good at understanding which gait pattern that they need, but it's the occupational therapist that understands more of the cognitive nature in which the person is going to be using that device. So we look at it one way, and then the occupational therapist looks at it the other way, and both really play an important role. So if you give somebody, say, the therapist goes, this is the perfect device, but then the occupational therapist goes, but they don't understand what this is for. So it's kind of like, well, let's figure out something that they can understand, they can use, and then we can kind of come up with the right device. So I've always found that if you put the two minds together, you'll always come out with the best choice for the patient. And that's really what you want to do. At the end of the day, it's not a battle as to who makes the choice. It's like, how do we get together to make the right choice?
Thank you very much, sir. Because I've always said the patient comes first, and so it's never whether it's a physiotherapist or an occupational therapist, but the patient is the center of the patient has the center of the interest of the rehabilitation team, so to speak, or the medical, the multidisciplinary team. So everybody is looking out to the best interest of the patient. So thank you very much for that answer.
Oh yeah, no, perfect. Yeah, I used to work in Boston at a hospital called the Spalding Rehab, and we found that we were always kind of looking out for each other's blind side. And that's the way I like to look at it. It's like sometimes I'm looking at something and I'm not paying attention to another side I can't even see. And then the occupational therapist will come in and go, well, this is what's going on. And I was like, oh my God, I didn't even know that. Thanks for covering me. And thanks for having my back. So that's what's really cool about, discussing those types of things from each perspective. Cool.
Thank you very much.
Oh, you're welcome.
I also have a question here.
Hello?
Go ahead.
Was asking
Hello?
when do trunk rollators come in reference to mobility?
Say that first part again.
When do you prescribe a trunk rollator for a patient? For instance, you have a patient with a neurological condition or any other condition that affects mobility.
So if I understand the question right, you're saying at what point do you decide which device to use?
Yeah, for majorly the trunk rollator.
The correlation between the two? Is that,
Yeah.
am I? Oh, okay. So what you're trying to do is each patient has their own way of actually approaching the mobility thing. So they might be afraid of falling. So
Yeah.
even though you think they can do crutches, it might be better in the beginning to use a walker. There's something that's a little bit more stable, and then they can get their confidence to build up. And then by working with you, you can challenge them in a safe environment. That's why the gait belt is so good. Because you can say, listen, we're gonna kind of put you in a situation that's gonna make you very nervous, but I'm here and I'm not gonna let you fall. So a lot of times what I do is I put the gait belt on and I have them stand up, and I'm kind of like, you're kind of off to the side, but to the back of them. And what I do is before I even get them going, I just give them a good swift tug towards me. And it kind of shocks them a little bit at first. And I say, see, I got you. I'm not going to let you go anywhere. So then they feel a little bit more confident and, exploring the next big step on how do I move to the next challenging device that would get me to where I want to go. And that is like just maximizing my mobility.
Yeah, I can see Dr. Kate is assisting here. I was asking about the trunk rollator, the gait trainer.
Which I'm not familiar with that.
The rollator, the walker that's all on wheels that has the seat for you to sit down.
Yeah.
Oh, okay. I got
We just call it a rollator here. I was very confused. I thought you were saying trunk rotator, and I'm like, gait trainer? So we were confused, sorry.
Yeah.
That's the one that has all four wheels and then
Yeah.
sometimes flip a little
Something-
thing down the seat.
Majorly the CP kids use it.
Yeah, so when you start to think about the two wheels in the front, when we progress the person from all four, like the legs don't have any wheels, very stable. And then we go to two wheels, actually, they can show that we can rely on them to be safe with two wheels, right? Four wheels, now you're really kind of taking this person out on kind of the rough road kind of thing. This is where things get a little tricky, right? So here's something where they might have good strength, but what's happened is a coordination or their sensation is off. So in that case, they needed more for stability, and the four wheels allows them to do that. And something like, as we talked about the progression from crutches to cane, right? We had the crutches, and then we had the large base quad cane, small base quad cane, and then finally the cane. You could look at it the same way for the walker. If you had just four legs coming down, that's really stable, person's getting better, showing a little bit more reliance and safety and strength, then you move them to two wheels. And then finally, if they're doing really well with the two wheels, then you can start to challenge them with the four wheels, what you call the rollator, yeah. Yeah, and what's good about the rollator that the other things don't have, and it's because they have four wheels on them, that they have brakes.
Yeah.
So what happens is if the person's feeling like it's getting out of control or they're getting out of control, they can put on the brakes, and all of a sudden now it becomes like a regular walker with just the four legs on it,
Yeah.
Yeah, that help answer the question?
Thank you so much.
Okay, great, thanks.
Is
Question
there
over
a-
here.
is
Question.
there a- Sorry, real quick, there's one in the chat box. Do you have a place where you would recommend to get good quality products? Is there a specific company that you recommend?
You know, with the internet, I'm always surprised by what the internet offers. So a lot of times you can find suppliers that could offer the device that you're not even aware of. And then what you can do is with that, you can actually start to explore pricing and availability, accessibility to the equipment. But the internet has just opened the doors on this. I mean, you think about something like Amazon, you know, 10, 20 years ago, Kate and I would never even think about going on Amazon to get a device. I mean, that was just not in our mindset. But now, I mean, who knows? They'll be able to have that device delivered to you by drone. Who knows? I mean, this is getting crazy, but I would use the internet as a tool to really explore, like, this is what I need for the patient. This is what I'm looking for. Can you get it to me? Yeah.
Question.
All right,
have
guys,
question.
I hope I didn't
I have
bother.
question.
Oh, you got a question? Yeah.
Yeah, thank you for a wonderful discussion and presentation. I would just like to come up on these mobility devices. We can't talk mobility devices without also talking about transfer. When using these mobility devices, linking with daily activities like toileting from sitting to standing and walking, is there any other addition of using these mobility devices during transfer? Let's take an example of a spinal cord injury or someone with a total hip replacement, from toileting to standing, and use those mobility devices. For example, the way we are using them while walking are the same from using while we are doing our daily activities, like toileting from sitting to standing, and keep working. Thank you.
Yeah, if I understand the question, I'll repeat it. What I think your question is, like, how do you really start to look at something like a spinal cord patient where you're trying to think of how to progress that person in mobility. And depending upon what level of the spinal cord injury occurred, if it's equally paralyzing on both sides, or maybe not on the other side so much, how do you get them to advance in that way? And in the United States, they're using a track system. And it's really kind of interesting because the track system attaches to the ceiling. And a person, you put the harness on the person, you hook them up to this thing. So it's somewhat suspended. But the interesting thing is that you can adjust how their feet come to the ground. So you can have it come down a little bit or a lot. And so by doing that, usually working with like occupational and physical therapy together, they're doing kind of motioning the person's legs as they progress the weight bearing part of it, but they're suspended. And then as they start to actually explore that a little bit, then what they do is they start to introduce, let's say, a walker, because that one we know is the most stable. So they start to introduce a walker while they're still suspended, but they're allowing them to bear a little bit more weight on the leg. It's really fascinating how they do this. So they have two systems. One is that it attaches to like a track along the ceiling. The other one is that they use like a kind of a cage. And the person is suspended from the middle of the cage, but each of the four legs of the cage that goes around the person is on wheels. So somebody can push the cage, and then they can do the same process about adjusting how much of their foot they want on the ground. And then they can introduce it. Somewhat fascinating, but I've seen both versions, and I think both versions work really well.
Well, thank you so much for coming. I don't want to keep you past our time, but I really appreciate this presentation. It was wonderful. And if anyone has any follow-up questions for Dr. Carley, you can send them to me and I will forward them on. How's that sound? Does that sound like a plan? All right. Thank you, everyone.